Hello. Are we broadcasting now? We're good, right?
Yes.
We are live. IVF Babble is now presenting egg freezing in the context of COVID. We're really excited to have you. So excited to be here. We have a whole panel of experts to talk about every single aspect. We don't want you to hold back in terms of your questions because we have plenty of time to dive deep. My name's Serena Chen. I'm an IVF specialist and a physician in New Jersey in the United States, and I do freeze eggs, and excited to talk about this, one of my favorite topics.
Great. Next slide, Tracy, please.
So,
yes, you go ahead, Dr. Chen. Do your
rules of engagement. We just want everybody to be nice and to each other. This should be a safe place. It should. We want everybody to protect their privacy if they want. We do want you to address everybody through the chat. You can put your questions there. Maybe everybody starts saying hello to each other right now, because then we can know where you're from. We tend to get people from all over the world, which is really, really nice. But if you don't want to chat, that's fine too. But we would like to see your questions, because that's really what we want to do. All your burning questions about egg freezing, this is the place to ask them. But be nice to each other. Thank you.
And please, in the chat section, change the to section. It's going to default to all panelists. So please change it to, it's supposed to be all attendees and panelists. Sorry, not participants. It's supposed to be all attendees and panelists. If you can change that.
It says all panelists and attendees. I just sent all hello, and Dr. James sent everybody a hello also.
Perfect. Great. Next slide. So we're excited to talk to you today about egg freezing. And what I'm going to do is have everybody who is on here, with the exception of Dr. Amy, who's going to be joining us soon, just introduce themselves real quickly in the order of this slide, and then we'll get to the information that you've been asking about. So Dr. Nicopoullos.
Hi, I'm James Nicopoullos. I am a gynecologist and clinical director of the Lister Fertility Clinic in London, and a bit like Dr. Chen, sort of lots of interest in egg freezing, and I think it's a really important topic that we're covering today.
Yeah, and you met me earlier, Serena Chen, IVF doctor like Dr. James, but in the United States.
I am Dr. Braverman. I am a clinical health psychologist in Philadelphia, Pennsylvania, in the States, and been working in the fertility space for a long time, and also excited to talk about the freezing eggs, because I think it is lovely that it is now an option for everybody to have to think about and ponder.
Hi everyone, I'm Valerie Landis. I'm a 3-time egg freezer and a fertility advocate in the space about egg freezing, with a website called experience.com, a podcast called Eggology Club, and I'm currently in the process of making a documentary film about the egg freezing experience as well, called This is Egg Freezing.
Val, can you put your information in the chat?
Sure, of course.
I'm Monica Moore. I'm a nurse practitioner from the States, and we have Sarah and Tracy.
Hello, and I will be making notes today because I've already spoken to my 9-year-old daughters about how important it is to understand about freezing your eggs so that they don't have to go through the heartache.
Awesome.
So I have my pen and paper ready.
Awesome. Next slide. So before we talk about freezing eggs, I think we need to talk about the kind of background of it. A lot of very common question that we get is, if I do freeze my eggs, am I using more out of my egg supply that particular month? So I think maybe we can go over a little bit of the theory in terms of egg supply. One of our, either Dr. Nicopoullos, maybe, since Dr. Chen is muted. Can you talk to us about when we have the most eggs?
I think incredibly frustratingly, and it's a slide that I should probably take out of my egg freezing open evening because it's depressing. The most eggs a woman ever has is around a 20-week fetus before she's born. And thereafter, there's a kind of continuous decline. By the time you hit puberty, there's around 500,000 that are still there and sort of primed, ready to grow. And the key really is, at that point, there's a continuous treadmill of eggs coming through. And on any given month, you've got a certain number that are ready, primed, recruited, ready to grow in response to your hormones that you produce every month. In a natural cycle, if you weren't having egg freezing or IVF, they'd all begin to grow. In essence, one would end up winning the race. You'd release the one egg. The rest, in essence, would wither away and sort of disappear, and a new batch would come in later on. So the key really is that, with egg freezing, with IVF, whatever you're doing, when you're stimulating the ovary, it's really important to be aware that, you're not drawing any more out of your stores. All you're doing is sort of utilizing more efficiently or more effectively what would have come and gone anyway. And it's maybe sort of jumping the gun a little bit, but that's a question I'm often asked, and I'm sure Dr. Chen is, am I going to suddenly, bring on the menopause earlier, or am I suddenly going to have lower my egg reserve if I do IVF or I egg freeze? And it really is important to know that, unfortunately, every given month, we don't utilize the number of eggs that we have, and that's what we're trying to do with egg freeze.
Right, so just to be clear, we're born with a finite number of eggs, unlike sperm, which constantly regenerate. And each month, let's say as we're younger, maybe as we're young, 20 to 30,
absolutely,
start the process. Then there becomes a dominant follicle, so that's just one. And then anywhere between 19 and 29 then just get reabsorbed in the body, but they're still withdrawn from that egg bank that we have. So
Monica, it's possible. It's possible it could be hundreds of eggs that we lose. Like if, technically we're starting puberty around with 500,000, as Dr. James said, and you end your periods at age 50, if you do the calculations, it could be hundreds of eggs that you're losing each month. And as he said, IVF doesn't make you lose more or less. And you could be on birth control pills and, losing eggs, or pregnant and losing eggs. It's just the natural process of human female biology.
So I'm sorry, Doc, go ahead, Dr. Nicopoullos.
No, I was going to say I completely agree. And in essence, there's two processes. There's a process from, I was about to use my really bad airport analogy, but I won't. I'm going to do it. It's a really
do it. You have to say it now.
Okay. We're all really bored in an airport, and we all get on that horrible walkway that goes from an airport to your departure lounge. Okay. Imagine that continuous treadmill is the process of eggs going from your stores to the point where they're ready to grow every month. Once they get to that departure gate, they're ready to grow and can respond to your hormones, and that's when one of those becomes a dominant follicle. That process on that treadmill from the airport to the departure gate, we can't do anything about. You're continually losing loads. So unfortunately, loads of those will actually disappear before they even see the light of day, and we can see them on scan. So we lose probably hundreds there, and you're left with maybe 10 or 20 every month ready to grow. And it's those that can basically fly in response to your hormones, one in a natural cycle or lots in response to stimulation. So we kind of lose two batches. Does that make sense? Is that a really bad analogy, or does it work for anybody else?
No,
it works. Dust off what it's like being in an airport.
I think we've all forgotten. I think we've all forgotten since COVID. But I would just add, as a patient and a fertility advocate, that egg freezing is a way to kind of save those eggs from disappearing that would naturally cycle out anyways.
Absolutely.
Exactly.
You're kind of salvaging the ones that you would have not used anyway because of that one dominant one. So, okay, great. So next slide. This is a picture from a book that a lot of us use, the Spiroff book. And, this is one of the reasons we talk about freezing eggs. So the green line, Tracy, can you make your cursor go on the green line? Just along it. Okay, so that is, so age is on the bottom, and that is the miscarriage rate. The miscarriage rate goes up as the purple line, which is the percent of maximum fertility, goes down. And you can see this happens precipitously between, in the 30s and 40s. So what is the reason for this, one of the doctors?
So there's this, so there's two things that we think about when we talk about eggs, two big things, and that's very roughly kind of quantity and quality. And this miscarriage and fertility are related kind of to quality, because all of our eggs, when we're born or throughout our lifetime, when the eggs are made, we don't make new eggs. New sperm is made all the time, but new eggs are not made. They're just, as we talked about before. So you just have all these eggs. They're sitting, most of them are sitting in this odd state of limbo, where they've started the process of dividing up the chromosomes correctly, because eggs and sperm need to have 23 chromosomes, unlike people who have 46 chromosomes. And that's because when the egg and sperm meet, 23 plus 23 will equal 46. And then you have a person with a normal number of chromosomes. The vast majority of miscarriages that occur in humans are due to aneuploidy. That's an extra or missing chromosome. So an embryo that has either less than 46 or more than 46 chromosomes. And most of those abnormalities arise during the process of fertilization, where the egg is in this weird limbo. The process of dividing into 23 chromosomes does not happen until the sperm actually fertilizes the egg. That sets into motion this very complicated process to make sure that the egg has 23 chromosomes, merges with the 23 chromosomes of the sperm, and then makes a normal embryo. And so many things can go wrong during that process, and you can end up with an extra chromosome 21 that could result in Down syndrome. You could extra chromosome 16 that will lead to the most common cause of miscarriage, trisomy 16. And for some reason, as you get older, those mistakes that happen when you divide up the chromosomes, even though they can happen at any point, they could happen when you're 21, or they can happen when you're 41. But when you're 21, those mistakes seem to happen maybe 21% of the time. And when you're 41, they maybe happen 80% of the time. And so that causes both the decline in fertility and the rise in miscarriage. Now, there can be other things involved, but that's like a very dominant effect. And it does seem that no matter how fertile you are, so let's say you're very fertile and you start up here, or you're not very fertile, you start up here, as you get older, everybody goes down. So that's universal, the decline in fertility. So maybe you are more fertile than other people, but your fertility will decline with age. And it seems to be related mostly to this abnormal number of chromosomes or this aneuploidy issue. Did I address that?
Yeah, so Dr. Chen, so when we're thinking the reason to freeze eggs is for a couple of reasons, which we're going to talk about in a minute, is we're trying to freeze eggs at maybe this, where before the green line goes up and before the purple line goes down.
Exactly. This graph illustrates it very nicely, because if you look on the left side of the graph, the miscarriage rate is low and the fertility rate is high, and the left side of the graph is a younger age and the right side of the graph is an older age. And so it is easier to freeze more high quality eggs in younger women than it is in older women.
Anything to add, Dr. Nicopoullos, or next slide?
No, nothing, absolutely nothing. I always agree with Dr. Chen.
Oh boy.
Okay. Uh-oh, you're creating a monster, James.
So, we have these tests out, and, none of the tests are perfect in our world, unfortunately, just give us snapshots and ideas based on data. But I think the first question might be easier to answer than the second one. So how do we determine egg quantity? And feel free to use the pictures here or not if you don't want.
Shall I start? There's two really good markers of egg quantity. One, in essence, as you've shown here, is by scanning, because, again, going back to what we said earlier, the more eggs you have left in your stores, the more recruited every month ready to grow. So by scanning and counting those little black areas, so black is fluid on a scan, so each of those little black areas is a follicle with an egg in it, hopefully ready to grow. So the more of these little follicles you can see on scan, the more eggs you're likely to have left in your store as a marker of egg quantity. The other good marker of your egg reserve is this AMH blood test. AMH is anti-Müllerian hormone. And again, it's a hormone produced by these tiny follicles that are ready to grow at the beginning of each cycle. So again, the more you've got in your stores, the more are there, the more are producing AMH. So these two tests are the key, the scan to count the follicle number, and also this AMH hormone. And the key, though, is that, in essence, they're stock checks of your egg number. And as a stock check, there can't be a one-size-fits-all, because we know that a 20-year-old has got more eggs than a 50-year-old. And the key is that people need to be doing these tests and comparing themselves to the reference ranges or the normal ranges for their ages. And what sometimes can get people really anxious is that they might Google their result and compare it to a figure they plucked from somewhere that may not be what we'd expect for you. And the key is having these tests done, getting somebody who knows what they're talking about to review them for you and compare them to what you would expect. So those are the key tests of egg quantity. And they're important because, in essence, the better your egg reserve is, the more eggs you're likely to produce if you stimulate for egg freezing. And it'll help give an idea of, help manage expectation in terms of what to expect, help perhaps make the decision as to whether egg freezing is right for you, because it may not be right for everybody. I'm sure we'll come back to that.
Dr. Nicopoullos, I'm glad that you mentioned, because there's reference ranges. So earlier in these studies, and correct me if I'm wrong, they were done on women who were subfertile or going through fertility. So for a long time, I don't know that they were able to compare those with people, because we weren't testing necessarily people for a while that were not in this high risk group. So somebody that just is 25 but experiencing infertility is going to have a different potentially level than someone who's 25 and comes in because they're curious. And so those need to be really, in my opinion, results discussed with a physician or clinician.
Monica, that's a huge thing, and we are seeing a lot of companies really pushing out a tremendous amount of advertising that seems sometimes a little bit coercive and inducing fear in people. And it's based upon all this infertility data. The vast majority of AMH data comes from IVF studies. There's very little data in the general population. And in fact, there are some of the general population data says that AMH is not correlated with fertility. So we cannot just use one measure. AMH is definitely very helpful to me to see, like, how much drug should I give a patient? How many eggs am I expecting to get at an egg retrieval? But the question of fertility is a bigger one, much more complicated.
And Dr. Chen, wouldn't it be correct to say that unless you're trying to actively get pregnant, you really don't know if you're suffering from infertility, because it's a partner situation with an egg and a sperm, a male and a female typically. And so there might be issues with the sperm, let's say, where there's no issues with the egg. And therefore, when you're looking at ovarian reserve testing, it's really just a snapshot and a fertility barometer, so to speak, of where you are today. But you could influence your fertility for the positive if you took fertility vitamins or exercise better or lowered your stress. So there's ways we can impact our fertility for the better. Not smoking, those type of things. Yeah. So these tests are really just like a baseline. Where you are today doesn't mean that you have to stay there. Now, age is the most important factor. I would say that, obviously you can't control that. We're always getting older, but there are other factors that can help.
Yes, and freezing eggs is not the only way to preserve your fertility. I mean, one big thing is to, you stop smoking, you're extending your reproductive lifespan by a year right away by stopping smoking. That saves a tremendous number of eggs, because smoking directly kills eggs. So this is egg freezing and AMH are just small aspects of, a woman's reproductive potential.
And we're using all of these components to paint the bigger picture to see where we are in our fertility timeline.
Yes, exactly. Yeah.
So, and that will bring us to the fertility assessment question, which I want to get to because we're going to get there. But how do we know these eggs, let's say on the second picture, Tracy, can you put your cursor over the second picture and just around all the circles there? Yeah. So that ovary looks pretty robust. All those black dots are the follicles that Dr. Nicopoullos was referring to. And this is just one view. So here we see at least 10. And if we move the probe, probably more, which looks really different than the top one. Can you go up to the top, Tracy? Yes. So there we just see one. And maybe if, there's a couple others that we can envision there. So these called antral follicle counts are very different. These two patients are probably going to have a really different conversation with you afterwards, at least in terms of how they would respond to fertility medications. But how do we know all of these little follicles are good quality? Do quantity and quality always go together? And how do we test for quality besides age?
The honest answer is we can't. And there's, frustratingly, we've got these markers of quantity, but realistically, the only marker we have of quality is probably age. And we can't really assess in advance of seeing these eggs or the embryos that these eggs create in the lab anything about quality. We know that the age is the best marker because we know how success rates of fresh or frozen eggs and embryos goes down with age. We know that even if you look at somebody who collects the same number of eggs, how success rate also drops. And that gives you an idea of the impact of age on quality. So frustratingly, we don't really see the quality. And even after we freeze them, often, unless they're very, very poor and the lab, it's clear, even when we freeze them, beyond knowing they're mature, we can't really tell much more about the genetics of them.
Yes, which we're going to get into later when we talk about the kind of psychology and the fact that this is, this procedure is meant to instill hope, but I wonder sometimes if we are falsely reassuring people, which we'll talk about.
I did want to ask Dr. James, how much stock do you put into antral follicle count? Because everybody talks about antral follicle count. And in my experience, that's a tough one, and patients are always asking about it. And I would say, I love, Monica, I want to get these slides from you. You have some great slides, and the top and the bottom picture do look very different. But honestly, they could come.
Dr. Chen, can you just say what antral follicle count is? Because I was supposed to put it up here, and
okay. Those are the, when you count those little black circles and that you just did, like Monica, you said the bottom picture maybe had 10 and the top one maybe had 1 or 2. That we count those on both ovaries, add them up, and that's your antral follicle count. Just the resting follicles. And there's a lot of stuff on Dr. Google about that. But you guys, number one, we have to remember Dr. Google didn't go to medical school. Number two, these two pictures, and Dr. James, maybe you can say whether you agree with me or not, but honestly, depending upon who is doing the scan and what their objective is when they took this picture, which is one single slice in multiple slices throughout this ovary. This is 2-dimensional. Ovaries are 3-dimensional. These pictures could be from the same exact person, and you could get dramatically different antral follicle counts depending upon the training of the person, the mood they're in, what they're looking for, and those types of things. My own doctors, if we are not specifically, say, looking at an egg donor and trying to decide on a drug dose and very carefully doing a lot of pictures and counting the antral follicles, we're like, oh yeah, there's 6 there, and because that's not clinically important to us that day. And there's tremendous variability in antral follicle count between doctors, and then also with patients on different days, and whether they're on birth control pills or not. The bottom picture could be the same person off of birth control pills, and maybe the top one, she's on birth control pills.
It also matters what day of her cycle, correct, Dr. Chen?
Yeah, that can make a difference too. Absolutely.
I'm for once, I'm going to agree and disagree. I think that I completely agree that, most of the AMH testing now is very similar across the world. And I completely agree that the antral follicle count is dependent on the quality of the person scanning, how easy it is to see what you need to see. and also the quality of your scan machine, and that makes a massive difference. I think there's differences of opinions as well on what size follicle counts as a natural follicle from country to country, which is a factor. I think there is better evidence now that you can probably take a natural follicle count in most days of the cycle and get an idea. So we tend to be less worried about day of the cycle in terms of follicle counting. But I think most of the time, thankfully, your AMH test result will mirror your follicle count result. So if one is good, the other one is good. But sometimes you do get disparity, which is really hard to then counsel your patients about what the reality is.
And just to clarify,
Dr. James, you would feel more comfortable with the AMH as opposed to, it is confusing when they don't agree.
If I had to do one test for an egg reserve, I would do the AMH blood test. Yeah.
And just to clarify, for patients, AMH is the blood test, and antral count, which is antral count is AFC, is your ultrasound wand that is put inside your vagina. So the round wand that goes inside.
Exactly.
Yeah.
So are we missing anything in terms of this patient's fertility assessment then? Somebody goes in and they want to get an idea of, whether they should freeze if they're where they're supposed to be according to their age. We talked about AMH, we talked about antral follicle count, and, and I think I mentioned age. Anything we're missing in terms of the fertility assessment then?
I think I would just add that this is how you do your baseline testing to know where you're at, and if you're a good candidate for egg freezing. So this is how you begin or start the egg freezing process, is getting this blood work done for your antral follicle or AMH, and then your antral follicle count with the ultrasound.
Monica, maybe you're going to cover this later, but you have it at the bottom. Age, obviously other factors are important. Age is important. Things like smoking, medical history, if somebody's had, chemotherapy or radiation. What if somebody has a family history of premature ovarian failure? Those things can make a difference when you're trying to decide risk factors for egg issues.
Perfect. And so we saw in the previous slide, the green and the purple lines, that, your fertility potential goes down, your miscarriage rate goes up as you age. So then what is the window for freezing eggs, age window?
Dr. James, what would you say?
Dr. Me. Sorry. Listen, there is no absolute right and wrong. And I think that, some countries and some sort of regulatory bodies have kind of stipulated that number. And I think it's really difficult. I think it's actually wrong to come up with any absolute figure. I think at the end of the day, it's a real balance, because, there's two extremes. At the end of the day, the sooner you freeze your eggs, the more successful they're likely to be, and the less you will probably need to achieve what you need to achieve. The counter argument to that is that you've got no idea what life's going to bring at 25. So is that really the right time to be freezing your eggs? Maybe for some, but for others, no. So in contrast, the later you freeze your eggs, yes, you might need more to achieve the outcome, but the more likely you are to actually need to use them. So it's a real balance. I think we know that overall fertility declines very slowly, if at all, until your early to mid-30s. Declines a little bit quicker to 37, and then does decline quicker thereafter. So there is an argument to say that by the time, perhaps, and it's not right for everybody, but perhaps you begin to approach your early to mid-30s, if at that point, having a family isn't imminent, that's the time to really think about it, because you'll still get a good success rate and you're more likely to use it. I have a little bit of a concern that people who perhaps freeze really, really young, but they're putting themselves through a lot physically, emotionally, financially, they may never need it. But again, it's my job to give them the pros and cons, and if it's right for them, it's right for them. And that's why I think I really enjoy the egg freezing consultations, because it's as much a social discussion as it is a medical one, because everybody's reasons for doing it, everybody's situation is different. There's no absolute. And equally, we've had people who have come up in their early 40s who have said categorically, I am not going to have a baby until I'm 46. I'm not ready. I'm not going to do it. And although 41 isn't an ideal age to freeze your eggs, when somebody says to you, is freezing my eggs at 41 or 42 likely to give me a better chance than trying naturally at 46 or with IVF at 46? The answer is yes, of course. So for them, it may be right to do it even then. So it's about, putting everything together and giving everyone the options.
As a patient, I think I would suggest that younger is always better. And if you want to save money over the long run, I think that freezing younger gives you the ability to have better quality of the eggs that you freeze, and that then it takes the pressure off, because a lot of social changes has really developed in the last 10-15 years of how we date, how we delayed marriage, how we we don't even start our families until later in life. The first pregnancy has gone up by 5 years, the age in which a woman gets pregnant. And so I think it's safe to say that we've become an individual culture, society, and that due to those aspects, we're not typically settling down and creating families like we used to in the past. And so therefore, if you freeze when you're not only younger, but have the time to do it, then you can freeze less amount of times. Like, I froze 3 times because they were in my 30s and I needed to get a certain egg number, an egg math count number, to make it viable that I have a good percentage chance that it worked. Had I froze in my 20s, I could have just done it once and not had to gone through the entire process 3 times. It is very taxing. It's very expensive to buy the drugs. And I would argue that if a patient's ever considering this, I've never heard a single patient say they wish they didn't do it, even if they didn't use their eggs or even if their eggs didn't work. So I think it's safe to say that younger is always better, and that if you're considering it, learn all the facts, get your basic ovarian reserve testing, your baseline testing, and then check back in it a couple years if you're not ready right now. There's no pressure, but learning about it, understanding the techniques, hearing about all the advantages, I think that piece is the understanding, the key understanding that's not out there or talked about on a regular basis. It's not part of sex ed or education like other things are. We just give women birth control.
I think that's a huge point. I agree totally with you, Valerie, and Dr. James. I couldn't agree more with what you said. And that's why Sarah is doing the right thing. She's taking notes for her 9-year-olds before puberty, because really this should be part of general health education for everybody. It shouldn't be like, oh my God, I'm having an egg emergency. Now I need to run out and have a panic attack and get tested. This should be something like, this is just normal human health. We should all know these facts. And then people, the more informed they are, the more autonomy they have over their own choices, which, it would be nice to have choices. And I'm just like Dr. James. I don't set an age limit. And when people come to me and feel like, do I have to freeze eggs right now because I'm 25 and don't think I'm really ready? I'll be like, no, but it's great that you're here because you're learning so much. And you can decide, let's check you out and address all your concerns. And then you decide, do you want to freeze your eggs now or don't you? But at least you are armed with the information so that you can make a decision. Ultimately, you don't want to have regrets. You don't want to say, I wish I had. And the only way to prevent that is to be informed. So everybody here today, I think you're doing a great job because you're here. I did have a question about the UK, because in the United States, egg freezing has become a big business. But we are getting more and more insurance mandates for egg freezing for medical issues, especially cancer. I'm wondering, what is the situation in the UK, and Europe, what's covered, what's not, what are people doing?
I think that in terms of NHS coverage, I think in some areas, again, it's dependent on where you are, but in most areas you can do egg freezing for oncology reasons, for fertility preservation if you're about to have chemotherapy. But again, it depends on area by area, and it's one cycle. But there's no coverage thereafter in terms of government or state funded for egg freezing. There are some insurers now, predominantly with some of the big corporates, that that do offer egg freezing for their staff, which is great. So that's beginning to trickle through. And again, I just kind of mirror what you guys said. There's a nice study that was published a while ago, and there's lots of them now that I use in my egg freezing open evening that says exactly what Valerie said, in that 90% of people over 90% of people froze, would say they do it again. Interestingly, 70-75% of them say they should have done it earlier. So although I've said there's no right or wrong, there is that feeling once you've done it, why don't I do it earlier?
There's a question for one of the physicians in the question and answer. Oh, did somebody just type the answer in?
Which one? About the long?
About I did that one, but there's do e-cigarettes and vaping, are they still as problematic?
Yeah, that's a good question, and I agree with Valerie. All smoking is an issue, but I don't think there's like precise studies. But no, we don't want you to smoke. It definitely can impact you. But are there as many studies on vaping as opposed to regular cigarettes, or e-cigarettes compared to regular cigarettes? Not quite as many studies, but it is still an issue.
Okay. Next slide, Tracy, please.
Bear with me.
So we talked about a couple of these issues in terms of why would anyone consider even doing egg freezing. So originally it may have been because of cancer treatment, and that chemotherapy and radiation or treatments are gonatotoxic, so they can, definitely are detrimental to ovaries or gonads in both. What in terms of other reasons for preserving eggs? What are the other reasons? Why did you do it, Val?
Well, so it could be that you just haven't met the right parenting partner. That's often a common one I hear a lot. It could be that maybe you're pursuing secondary education or a master's degree, or you're studying to be a doctor, or you're in some kind of time period where you won't have the opportunity to start a family. It could be just you are unsure if you want children at all. It could be reasons where maybe you're figuring out a relationship and figuring out if you want to have kids together. It could be that you just want to preserve your option for baby number 2 or baby number 3 or family planning choices. It could be for cancer or health concerns. It's really interesting. I had a couple of women that froze their eggs and then sadly got cancer later in life, and they were so thankful that they froze their eggs early before they learned they had breast cancer or something traumatic, and because then they didn't have to throw that piece of the component into the mix. But most of the time, the women that I talk to, it's because of the relationship piece not being put together or completely sure if those components are aligned, and finding the right timing. Also, when we delay pregnancy, we increase our financial stability or our financial earning power by delaying parenthood, although that's not always ideal, because then you have the after effects of having a harder time getting pregnant. So that's why egg freezing could be a good choice.
Thank you. Dr. Nicopoullos, is there any time that a couple would come in to see you and they're doing IVF that you'd also recommend egg freezing in addition to embryo freezing?
Honestly, no. Not that I can think of off the top of my head, because I think that if they're genuinely there to have IVF to get pregnant, then my default normally is let's worry about baby number 1 before we worry about baby number 2, because they're struggling to get pregnant. The ideal scenario is that we do IVF and have extra embryos to freeze, but my concern is always that you end up freezing eggs when you're actually going to get pregnant, and then when you stop, at some point you've got to use those to get pregnant. So normally no would be the answer. There might be some little pop into
I would have a flip side. I think there is huge conversation that needs to happen with egg freezing versus embryo freezing, or creating embryos at all. there are a couple of examples where women have split from their partners, and if they had created embryos, then they would have the custody battle of those embryos. And so even if you're married to someone, it doesn't guarantee that that's going to be your parenting partner. So I think it's a very big discussion of understanding egg freezing versus embryo freezing. Obviously, there's advantages to embryo freezing if you're older, because the eggs may not survive the freeze and the thaw, but it also isn't on its way to becoming a human. So that might be a huge aspect too, especially in the religious concept, where you're freezing just the gamete material, freeze sperm, freeze eggs. That's what I chose to do with me and my partner. And so that gives us a lot of opportunities that if we end up not being parenting partners together, I can still create embryos with my eggs with another partner. So there's a lot of advantages there.
I agree. I think there's two sides of that. I think that absolutely agree with the religious aspect, and a lot of the early data with egg freezing came from Italy, when the Catholic Church wouldn't allow embryos to be frozen. So completely agree with that. I think the second side, and I think my answer to Monica's question is very much based on a couple who were in front of me who are saying, I want to have a baby. And that couple, I wouldn't suggest they freeze anything, because they want to have a baby, they should be putting embryos back. I think a couple who are in front of me who want to preserve their fertility, I completely agree with Valerie, for whatever reason they want to preserve their fertility. And the awkward question I'm sure Dr. Chen and I'd often get asked by a couple who are talking about fertility is, what should I freeze? And the honest answer I will say to them is, I'm thinking about both of you, thinking about the female partner. The only reason to freeze eggs rather than embryos is absolutely what Valerie said. If you're worried about you might split up. Awkward to say to the two of them together, but it's absolutely true.
It's happened to you before, right? The guy
had a mutual friend that had happened to you, right?
Yeah.
So
Yeah.
The guy leaves the room. You're in there by yourself with the woman, and they're like, "By the way, I think I want to freeze my eggs."
Yeah, absolutely.
Yeah.
I got those emails.
Yeah, we've all been in that position, and Valerie, you're right, long term, and this is why I kind of discourage embryo freezing for cancer patients, even when they're married, because I worry about the impact, because we have a 50% divorce rate in the general population. There's a lot of evidence that the divorce rate in a couple that is dealing with a severe life-threatening disease like cancer does have a much higher divorce rate. So I worry about that. Also, a lot of times, not that it takes that long to freeze, much longer to freeze embryos versus freezing eggs, but obviously egg freezing often is done emergently. We're not really doing a lot of testing or things like that. We're just like, grabbing some medications and going. I've been in those conversations where the oncologist will call me and say, I just kicked the fiance out because he was a dick, and you're freezing X. I cannot tell you how many times that's happened, because cancer is very, very stressful. So, this conversation, egg freezing, is not really just about egg freezing. Like Dr. James, I think, said it before. I can't forget exactly how you put it, but it's about your whole life. It's not just, I'm going to Dr. James to freeze my eggs. I'm going to Dr. James to talk about my vision for my whole life. What are my fears? What are my wishes? What do I want? I hope he can help me with that. And that is one of that's probably why we love talking about egg freezing, because there's so many aspects to consider.
And that's a really hard question for you as a physician, because you don't know the trajectory of any life, where someone's life is going to go and the choices that they're making. And so that's really hard as a physician to tell a patient, here's how, based on what you want, here's what you should do. They still have to come to that conclusion themselves. And I think that's a really tough thing, because there's a lot of emotional aspects that aren't brought up. with the idea of conceiving naturally versus conceiving with fertility treatments or help, having to be an older mom or a parent at an older age. There's maybe LGBTQ questions if they are struggling with or have a different sex preference. So there's a lot of concepts that maybe can't be addressed in an office visit.
But once an embryo is made for a heterosexual couple, it's linked to that relationship.
Yeah.
And so
you're kind of stuck together forever. And sometimes it can result in really awful
Legal
things
battles.
like lawsuits and things like that. ASRM and actually does recommend, they don't put it in a guideline, but they do say everybody thinking about freezing eggs probably could benefit from a visit with a reproductive psychologist. And I see Dr. Braverman probably got...
She lost electricity.
Yeah, she lost electricity, so she's not here, but
yeah.
I'm sure but these are... These are big life decisions, and having a resource like Dr. Braverman and all IVF programs, all good IVF programs will be able to refer you to a really good reproductive psychologist that can help you try to unwind some of these issues, because they're huge questions. So egg freezing is actually very easy once you make the decision. I think the process around deciding whether or not it's right for you, maybe that's the harder part.
I think the biggest takeaway is that you can't unfertilize an egg from an embryo. So once you put an egg and a sperm together, they are mate for life.
Right.
The only thing I'd add, and we'll talk about it in a second, I think there may be a little bit of a transatlantic difference in our feelings towards the success rate of fresh versus frozen eggs and fresh versus frozen embryos that may tip me slightly the other way. I would still say if you are a couple, by all means freeze both. That would be the ideal scenario, frankly. But I think that nobody can be confident that a relationship will last. But I think if you're likely to use embryos in the short term, it will still be slightly my preference as a clinician. That's what I would say to a couple.
I think that's where if you get legal counsel and you both write out your wishes and intentions on legal representation, I think that if you do that before freezing anything, it helps if you're going to create DNA together.
It does help, but I think we all know about this big lawsuit in the United States with a physician who had cancer, froze her embryos with her fiance. The fiance, they agreed that she could use the embryos after, even if they got divorced. It was all in writing. He changed his mind. He didn't feel comfortable after she was cured and she was ready to use the embryos, and they were divorced. And there was a big lawsuit. And I think that a lot of these cases previously had been decided to say that you cannot force somebody to procreate against their will, even if you're not obligating them towards child support. But I think this particular case ruled in favor of the woman and said that because she had cancer, she was in ovarian failure, she didn't have another chance. This was her last chance to conceive. So the male was told that he would not have any parental or child support obligations, but he should abide by the original agreement. I don't think there's any right answer here. I think it is really tough. But you're right, Valerie. Getting a good reproductive lawyer ahead of time usually prevents a lot of those issues.
There's a lot of concepts that you just don't think about until a lawyer is, a fertility lawyer is helping you work through those feelings.
I don't know how it changes, from a regulatory point of view, in the absence of the cancer and what you do posthumously. In the UK, if you create an embryo as a couple, the male partner, and you separate the male partner is within his rights to say you can't use it, as is frankly the female partner. And lawsuits won't predominantly change that because it's a regulatory decision within the code of practice. There are certain scenarios where perhaps you could then be screened as a donor and become a sperm donor. It becomes complicated because there's a financial aspects, and that's when the lawyers come in. But the default is you can withdraw consent to that use, and we've all had scenarios of that can be heartbreaking when somebody wants a sibling for a child that they've had as a couple, and that can't happen.
I think maybe in the UK you might have a little bit more consistency and clarity, because we go state by state, and and people can sue over anything in the United States, so it's it can be confusing. So you can't use your Uncle Bill who does real estate. You need a really good reproductive lawyer
and mental health professional.
Yes.
Yeah.
I want to give you a couple statistics before we talk about these other questions. So in the United States, the way that we accumulate data is something through SART. And so the first time that we started looking at how many people went through an egg freezing cycle was 2009. And so that number in 2009 was 475 women, or cycles. Could have been the women went through more than once. In 2017, it was greater than 9,000.
Wow.
In the U.S. So a huge jump. I can imagine in 2019, it's probably much even greater than that. Most of the people, according to the studies that are out there, are really happy, like Valerie was saying. So 2016, 224 egg freezing patients, 60% reported feeling less time pressure when dating. Many said they felt more relaxed, focused, less desperate, more and more time to find the right partner. 96% of people in that study would recommend egg freezing to others. 2018 study, 200 women found that 89% were satisfied with their decision to freeze, even if they never used their eggs. But then there's another part of the story, and that's why I want to talk about the process in these next couple questions, is that there is, this can be disappointing in terms of if people don't have their expectations set in the beginning. And so one of the studies found that about 20% of people experienced moderate to severe regret because they either received inadequate counseling, didn't know what the process entailed, or didn't freeze a lot of eggs. So let's talk about what the process entails. And anyone willing to go over what if somebody wants to come and freeze their eggs, they were a good candidate, and let's say let's just put out there, they're 30, and they want to go in and freeze their eggs. What can they expect is going to happen in the next weeks or months?
This is one for Valerie.
Well, as a patient, you're given a drug hormone protocol that you'll be taking between the next 10 and 14 days, depending on how you're cycling. For the first week, I like to describe it as you're taking about 1 to 2 shots, maybe 3 shots in the evening. You have a window that you take those medications. They're follicular developing hormones, and typically they're in like a shot pen, or there might be a mixing one, and you'll take those in the stomach, or you can do them in the thigh or the arm, anywhere there's fatty tissue, and you'll do those consistently for the first week. Around day 5 of taking meds, you'll come in for your first scan. That scan will tell you your antral follicle count as your eggs are growing with these hormones, and we'll be able to monitor the process and the progress of those eggs developing. You want those follicles to grow between over 10 millimeters, so between 15 and 18 is a mature egg. And then by week 2, you come in about every other day to kind of keep monitoring those eggs, those follicles. And then by week 2, typically you're given a drug to prevent you from ovulating. And so that just keeps the follicles inside the ovaries and make sure that they keep growing. You're trying to grow as many follicles as possible at the same size and growth rate, so then you have the most mature eggs at retrieval time. Once you get to about day 10 or day 14, your doctor will tell you, okay, I think it's time for your trigger shot. The trigger shot then is taken, and then 36 hours later is your retrieval. And so that's a very timed procedure and timed injection, because we have to get the eggs out by a certain time period. And then the eggs are stripped and collected and counted, and then we make sure that they're mature level 2 eggs, and then they're frozen in vitrification media.
Awesome. And during the egg freezing, the stimulating part where you're taking the injections you were talking about, you can expect to go into the office in the US at least maybe somewhere between 5 to 7 times. Is that the same in the UK, Dr. Nicopoullos? Sorry to.
Yeah, I think probably the average is 4 or 5 scans over those 2 weeks plus the egg collection. So yeah, not massively dissimilar.
Okay, and is the egg retrieval process painful, Valerie? And then
I would say that the egg freezing process, the retrieval itself is not painful because you're kind of put under a light sedation or like a light anesthesia where you're out and you don't remember anything that happened. It's actually very fast. So it's about 15 minutes that the egg collection process takes, and then you're in the recovery. What could be painful or a little bit more, time to recover. Sorry for all the dogs at the house, but yeah, we're getting the mail. But what could be a little bit more painful is the recovery afterwards, because you become very extended, and you have to kind of like the ovaries are trying to heal. So it could depend on the trigger shot that you're given. Some trigger shots have kind of a hangover effect where others do not. I was given 2 different trigger shots during my experiences, and one I had a little bit more of a hangover, a couple days needed to really be out and resting, whereas another different type of trigger I was bounced back, and the next day I was back at work. Now I wouldn't recommend that. I think taking it easy and staying hydrated and keeping up your electrolytes, that and the salty snacks, which sounds counterintuitive, but it does help the healing process, is highly suggested and can help the recovery happen much faster. But yeah, just being mentally prepared that that's going to happen, I think, is key too.
And in terms of if you have a 9 to 5, 8 to 4 job, how many days of work can someone expect to miss?
It's very individual. I would say definitely the day of retrieval, the day after retrieval, give that, space to yourself. But I tell women all the time, anyone I talk to, that if they're doing this, to just block off the entire 2 weeks, because you're going to be fatigued, tired. You'll want to keep your strength and get good sleep, because you're growing these ovaries the size of, small melons. So it takes a lot of energy from your body to do that. So just give yourself grace that the whole 2 weeks, I just wouldn't plan anything. I wouldn't drink. I wouldn't go out. I wouldn't, it's not that you can't go to dinner, but your clothes are really tight. You don't feel awesome. It felt like I was a couple months pregnant. Like it wasn't like I, wanted.
Did it make you more emotionally labile, Valerie?
Oh yeah, for sure. I mean, I was definitely more emotional the first time than the second or third, but that was because I was mentally prepared for the emotional upswing. I mean, you're putting hormones in your body that are essentially mimicking like pregnancy to grow your ovaries the size large enough to be frozen. And you're growing so many of them that I think, you just have estrogen running through your body all over the place. So I think also being aware of like hyperstimulation and having that conversation with your doctor about your protocol, how intensely you want to be medicated, is a great conversation to have as well. Like, for example, my first time and my second time, I was just medicated on the normal dosage based off of my numbers. The third time I said, hey, this is my last shot. I really want to, push it to the max, maybe be borderline on the estrogen, levels and stuff. And I'm okay with the risk of hyperstimulating. I just want to, push it to the max because this is the last time I'm doing this. And it paid off, but it was risky. I mean, I had to monitor me really closely because of, that estrogen being so high and the risk of hyperstimulating.
And I love that you use the word, to have some grace for yourself, because really no one knows how they're going to respond, in my opinion, as a nurse, to these medications till they have these medications. So if you start to bite somebody's head off, Dr. Chen or Nicopoullos can give you a medical clearance note for your spouse or friend or any colleague or whatever, because I'm telling you, like the most seemingly feeling easy, even keeled people, when you go through this, you just don't know.
I always said it was kind of like my personality was taken to the next level. It was like a heightened level of whatever my personality was. If I would normally cry about something, I would, profusely cry about that thing. So just being aware that your emotion will kind of take this, roller coaster ride with you is good to know. I also think it's great that the stigma has really kind of dispersed a bit, because now you can tell people, like your friends and your family, without being embarrassed. or have this stigma attached to it. Like, hey, listen, for the next 2 weeks, I'm going through this process, this fertility process. So just be extra kind to me. I'd be really appreciative, So like you can have that conversation a little bit more openly than you've ever had before.
That's a great idea. And it is nice that people are more open about it.
Yeah, and I think that's so important too, what you said, Valerie, because a lot of people are like, how can I help you? And people don't know what to ask for, but what to ask for is accept me as I am these next 2 weeks. I don't necessarily need you to bring me like a dinner, but I might say,
I'll take the dinner. I'll take it.
Yeah, dinner's always nice.
Yeah,
dinners are acceptable.
But to say, basically just to say, give me some breathing room.
Yeah.
I don't know how I'm gonna
and lots of electrical water instead of wine.
Yeah.
We also have to remember not to have unprotected intercourse. We cannot guarantee that we are going to capture all the eggs. And if you are not planning on getting pregnant right now, there are like going to be some loose eggs around, and you don't want to take that risk.
Did the drinking wine make you think of that?
Yeah.
Dr. Chen, would it be safe to say that after your period hits, about a week after the retrieval, then it would be safe to presume sexual activity is normal?
Yes, but usually at that time, like it depends. If you made like a lot of eggs, for everybody, I bring them back at the time of the period and look at their ovaries, because some people still have big ovaries then. And so high impact anything, exercise or sex, maybe you want to take it easy when the ovaries are big. So I like to look at the ovaries after.
Okay, so protection and basic protection and birth control again would probably be a good choice.
Yeah, it depends on, obviously it depends on your goal. So, but I like to just look at the ovaries so I can tell the patient, okay, things are going the way they should, and you're back, and you have no restrictions now, or maybe your ovaries are still kind of big. Let's just take it a little easy for the next cycle.
Dr. Chen, that brings me up to another question. Some women have always asked me if they can if they can do egg freezing while they're on birth control or on an IUD. Do you want to address some of that question?
So I love it when people are on an IUD, because then I don't worry so much about people getting pregnant accidentally, although I guess theoretically it's still possible, but very unlikely. And being on an IUD, a lot of times that means that I can start the egg freezing process whenever we want. So IUDs are fine. We do a lot of our egg donors are on IUDs. So that's fine. Birth control pills, we want you to stop birth control pills. Sometimes some people respond in a way to birth control pills where their antral follicles get very, very small, and their hormone levels get super low. And that means that when I stop the birth control pills, if I start the injections right away, it ends up costing more, because I end up using more drug, because they just are a little bit slower to respond. So there are some people, depending upon how their ovaries look, where I will say, it might be helpful if you took 1 or 2 months off of your birth control pills before we start your drugs. Some people, it doesn't seem to affect them at all. So it just depends.
Oh, that's a really good point, because actually my third time I went off birth control for over a year, and it definitely helped increase my egg supply.
I think that the counter argument to that is that many people feel great on the pill and are really reluctant to come off.
Exactly.
And actually it can work beautifully in that you carry on the pill, and they use that at the time when they want to start, because you can come off the pill any day you want, get a period and start. So I've got to say I'm usually the opposite way, and I say to them, if you want to stay on the pill, stay on the pill, and when you use that at the time you're starting.
But you're still, they're not taking the pill while they're doing the injection.
No, of course, they're stopping it. That induces their bleeding, and then we can start.
Yeah.
And just kind of to go back to what Valerie said earlier, I think the key is this is really different for everybody. For some people, they find this physically easier than others. For some people, the logistics of fitting this in around life, and work is the hardest. So and the key is there's no right or wrong for anybody. Some people will be better served taking 2 weeks off because it's better for them. Some people, frankly, will be better off taking those 2 weeks to go on a nice holiday after they do it. And it's really, it's really hard to know. There's no right or wrong.
Totally agree.
All really great points. So the one study I mentioned in terms of the only percentage of people that had regrets. One was that they didn't understand the experience, which we kind of went over. The other is that they didn't make as many eggs as they thought. So Valerie mentioned she had 3 cycles. We had a reader email us just now that she's 36 and how many times can she expect to go through cycles. So can you talk about, why people need to go through multiple cycles? And then this is also a choice of people. This is a difficult decision financially for people to make at a certain time in their life. Because Valerie, you were saying, you would rather be younger than older. But if you're 23, I'm just making that up, you may not have the funds yet to do, like, let's say 3 cycles. So this is an important, I think, factor to consider when you're making this decision, because you may need 2 or 3 cycles depending on your age. So can you guys discuss your thoughts, and then maybe just say, if somebody's 36, how many, obviously we don't know that person specifically, but what would you talk to them about? And they have parameters that are consistent with being 36 years old in the fertility assessment. How many cycles would you tell them to plan for having in order to have enough eggs to get a good quality transfer?
I think you have to give them some numbers and some choices. I have a patient who started freezing at 42 with a very high AMH and froze over 100 eggs and now has a beautiful donor egg baby because none of those eggs worked. And then I have like a 38-year-old who froze 1 egg at 38, married at 42, failed 2 IVF cycles, and then has a beautiful little baby from her 1 frozen egg. So this brings in that whole crystal ball thing. We really just don't know. We tell our patients just our statistics. So I know that, up to around 37 or so, we're feeling like, 18 to 21 eggs is about a 90% take-home baby rate, just knowing what our fertilization rates, our blast formation rates, and our implantation rates are. Super, super rough. And for a lot of people, that takes 2 or 3 egg retrievals. For some people, that's half an egg retrieval. So we really don't know. And ultimately, I really feel like it's in the individual patient. At the end of the day, the important thing is that what you need to do for yourself is make sure all your questions are answered. And even if you have to see more than one doctor, that you feel very comfortable with your medical team. And at the end of the day, you want to be able to look yourself in the eye, whether you use your eggs or not, whether they work or not, and say, I made the best decision for myself. I have no regrets. So for me, there's no particular answer. It could be 0, it could be 100, it could be anything in between. Having said that, the vast majority of my patients are, up until now, have been doing only 1 egg retrieval. More recently, I've had a lot of patients who, maybe because of what Valerie's talking about, just more social acceptance, wanting to be like, okay, I bought a 2 retrieval package. I bought a 3 retrieval package. Like, we do our practice, my finance department gives like multi-cycle discounts, which don't make a lot of medical sense to me, but those are the finance people. That's how they think. You buy, it's like frequent flyer program or something. But so I am seeing more people wanting to do 2 or 3 egg retrievals now, but I have to say well over 95% of our egg freezing in the past has been like, people are like, okay, I did it. I'm glad I did it. Now I can move on with my life. So, I think it will change as we go on, but I don't think there's one single right number. I don't know. Dr. James, what do you do?
Yeah, and what you said at the start is almost like you're eavesdropping on my consultations. I think people will always ask that question, and there's no guarantee you could get 20 eggs or 30 eggs and not be successful and get 2 and it work. And similarly, we know that roughly under 35, fresh and frozen, about 1 in 15 egg gives us a baby. Between 35 and 40, around 1 in 22 gives us a baby. And it all depends how much reassurance, how much backup you want. And for some people, just doing 1 cycle, perhaps getting 5 or 10 eggs will give them the peace of mind. For some people, they will want 20, 30, 40, just because they want to maximize their percentage chance. But, we can't ever give any guarantee. So it's about counseling people about, what X number of eggs will give them in terms of chances. And then it becomes how much can I put myself through physically, emotionally, financially, and what's right for one person won't necessarily be right for somebody else.
I love statistics, but statistics don't apply to the individual. And I say
Absolutely.
that because, every person is going to have a different expectation. I think understanding that, each egg has between 2 and 12% chance of turning into a live birth, that's a huge timeline to consider. I mean, they have to go through the freezing process, they have to go through the thawing process, they have to go through the embryo process, then they have to be implanted, then it have to go through 9 months of healthy pregnancy. So there's a lot of things and mishaps that can happen. And I say, start with the first egg freezing if you decide you want to do it. See what your numbers are like. Every freeze is different. I literally had a completely different experience every single time because it's how many follicles can you grow at the same rate that are going to respond to the meds and then turn into a healthy G2 in time for freezing. And so you won't know until the process is over. So I always say start with one, maybe plan on doing more than one if you're in your 30s, and just mentally prepare for that. And then obviously, Dr. Chen, you were talking about the different financial benefits of doing multiple cycles financially. And so I think that's great too, that there's kind of like a frequent flyer for egg freezing.
Yeah.
It's nice. It makes the burden easy.
It's important that, we do sort of 3 cycle packages as well, but it's important that, Dr. Chen and I, most of us, we love what we do and we let the finance people talk about the finances. And it's important that, from my point of view, when we started a 3 cycle package, it was important that women weren't tied in. So, because it may be after 1 cycle you get the number of eggs you need, or maybe after 1 cycle you think, bloody hell, I'm never doing this again.
Right.
So it was important that women had the option after 1 or 2 cycles to pull out of that package. And that's the key. If you're going to do a package, make sure it's somewhere that gives you the flexibility to change your mind, because you don't know, as Valerie said, we just don't know until you do it how you're going to experience it.
Absolutely. Totally agree. Now, this brings into my big beef is that my personal position is that egg freezing is, for age concerns, should be part of good proactive reproductive health. And that if we covered egg freezing for everyone that wanted to do it in the proper way, we probably could save our healthcare system a lot of money, time, trouble, and heartache with all the time and just suffering that we see with infertility and miscarriage. So I don't think, I'm not really in the majority there. Our national society really right now only recommends egg freezing strongly for cancer patients. In New Jersey, we just passed egg freezing mandate to cover people with cancer, medical problems, and transgender youth. But I really feel like it's something that should be covered for everybody, because right now the burden, the cost of this process is upon the individual female. Yeah. And yet this benefits all of society. Having females be able to take their time to choose their partner, take their time to get their education, take their time to get settled and feel financially able to support a family. That is not just a female problem. That crosses all of society. We have a declining birth rate here and in Europe. That's going to only result in economic decline for everyone. It's a huge issue. We should be supporting all young women who are willing to, freeze their eggs, because it helps all of society and healthcare. So that personally, that's how I feel. But now it's up to the individual.
I would love to ask Sarah and Tracy at IVF Babble, if you had been given the option to freeze your eggs at a younger age instead of going through infertility treatments, would you have opted for that? Because you both are infertility treatment patients.
Yeah,
I would. Go on, T. Sorry.
There you go.
No. My answer is really simple. Yes. Yes, absolutely. Yeah. But I mean, I didn't start thinking about having children until I was 32. I didn't think I would ever struggle.
32 is a great age to freeze your eggs, right? That's a good age. What about you, Tracy?
No, I absolutely would have done that. And actually, I mean, I didn't really think about sort of having children until I was in my mid-30s, and I had an ectopic pregnancy. So, yeah, just kind of, I went through 10 years of quite a tough time, and actually, I had someone actually sat down with me in my 20s and said, look, number one, you've got endometriosis, which I didn't realise until my late 30s. But also, this is what you can do to give you time and might take away some of those 10 years that I eventually went through. I'll be telling my children, you're so wise to egg freeze.
I think, Tracy, what you said has just absolutely nailed it in terms of if somebody had sat you down in your 20s, and I think we spend so much time, or historically we spent so much time in the UK anyway, talking and teaching people about contraception and how not to get pregnant. But historically we haven't given, men and women the education they need about how fertility declines. And I think that's getting a little bit better, with you guys and generally in schools. But I think that's the key, and I think that's what's been lacking.
Yes, I totally agree, and it's really that way in the United States. Also, in general, in the United States, it's a very reactive, disease-based system. It's not about wellness. If you think about it, if everybody learned from babyhood on how to eat properly, how to have a good diet, control their weight, get regular exercise, all the resources put into that type of education, like, a nutrition consult, that doesn't cost very much money. But, a lifetime of obesity and high blood pressure, ultimately ending in like a kidney transplant, that can cost the system millions of dollars. And we're, looking at a ballooning cost of the healthcare system. We can afford to do really wonderful things and utilize super high tech, all this new technology for healthcare if we reduce the disease burden. And reducing the disease burden are things like this, like egg freezing, doing things proactively to try to prevent things like infertility, which can be very costly later on, which we know the prevalence of infertility increases very dramatically across the whole population with age. So it's something we know about. It would be nice if we could really do it for everybody.
So there's this movement in the women's health nurse practitioner world, at least in the US, and it's called like the one question or something similar to that. So anytime you see a woman for her annual exam, regardless of age, the question is, do you plan to get pregnant within the next 12 months? And if the answer is no, and they're young, then you should have a contraception if they want it. But if the answer is no, and they're starting to get a little bit older, that's the perfect opportunity to start talking about that, because that question is for everybody. So you're not biasing against anyone. In fact, you're opening up a conversation that you may not have had otherwise.
I love that initiative. I think it's called One Key Question. I think people want to Google it right now, One Key Question. And it was a private public partnership started in Oregon, but that, hopefully we can get that across the whole country, because that's a great initiative.
So the reason that the egg freezing data didn't come out till around 2009 is because our technology improved in terms, especially of being able to thaw, or having the good freezing process, the quick freeze, that when we thawed, we didn't have such a high attrition rate. So I think if you asked us before 2009 if frozen eggs were just as good as frozen embryos, that answer would be easy to answer. And that's why the ASRM, the American Association, lifted the egg freezing is, what did they call
it? The
ban,
or just for non-commercial uses in 2012.
Right, because the technology improved. So now we've gotten to the point where we're 10 years past the technology improving. But are frozen eggs just as good as frozen embryos in terms of thawing, and then in terms of implantation, and then having a healthy baby?
I think that it's a really difficult question, and I suppose the other question is it the right question? I think that there's certain things we know and certain things we don't know. What we know with certainty, from as much certainty as we can in medicine and from fantastic top quality trials, is that frozen embryos are as good as fresh embryos. We know that from great data, and we know that from a lot of data. increasingly we feel that frozen eggs are as good as fresh eggs. But from the UK perspective anyway, I don't think enough babies have been born as of yet to have that level of certainty as we do with the effect of freezing on embryos. I think we're getting there. We're more and more confident. But again, there aren't those top levels of trials that compare them quite as of yet. And in terms of comparing frozen eggs to frozen embryos, I haven't seen great studies. I know the SART data is quite nice, and they do publish it in terms of fresh eggs, fresh embryos, frozen embryos, and that's comparable. I can say with a lot of certainty that in the UK, that's not comparable. The UK data would suggest across the board that that's not true, but I think that's partly because there are a lot of clinics that don't do much for egg freezing, and if you are going to have your eggs frozen, you need to go somewhere that does a lot of it and does it really well, and that's got a good background in doing it. So if you look at the clinics that do it a lot, then they probably do it very, very well. But I think it's a difficult comparison to make. I've kind of sat on the fence.
But that was the basis of when we talked before about the couples, where you were saying, Dr. Nicopoullos.
Yeah, so I know that 97% of our very reasonably good blastocysts will survive the thaw process. As you know, maybe you guys are better, but we're not getting 97% of eggs surviving. And that's partly because the natural selection process has already got a little bit further with embryos. It might be an unfair comparison.
I think that question is comparing apples and oranges instead of apples and apples and apples and oranges.
Absolutely.
Or, it's just not comparing the two factors because there's so much at play here. Like maybe it might be a sperm factor, maybe the age of the egg. So.
Yeah, so I think that both of you are absolutely right about that. And when patients say, should I freeze embryos or should I freeze eggs? That's really so many factors go into play, and that's a conversation you have to know.
Individually have.
The physician has to know the whole picture to be able to help you figure out what the right answer is.
Yeah.
I think really frustratingly what I find is I think you still get some physicians who, I can't believe I use the term physician, Dr. Chen, you're making me into an American. You get some physicians who don't do a lot of fertility work who will still recommend somebody who's single to freeze their embryos because it works better. And I find that incredibly frustrating, and I think it's almost negligent because you're putting somebody physically, emotionally, and financially through something they may never use because they end up in the right relationship and with the best one in the world, they're not going to want to have a baby with an embryo created with no sperm. Yeah. So it's a no-brainer for a single woman.
Dr. James, that's so spot on because you're right. If I were to have made embryos and then end up with a partner that I really wanted to be with, that now we're not having our together baby. We're having a baby that I have with a donor. And so I think that understanding that key factor is huge. It's a good point. That's where the advantages of egg freezing come in.
Yeah.
Because that's the whole reason why we're freezing is because we don't know who the parenting partner is.
Yeah, give yourself a choice. Yeah, absolutely.
And I think the big thing right now is that compared to slow freezing processes, the new process of vitrification has made this a very, very valid choice. Whether, like maybe Dr. James is saying, okay, well, we have a few thousand babies born from frozen eggs, but we have 1 million babies born from frozen embryos. Obviously, you have more data on frozen embryos. Worldwide, 7 to 8 million babies born from IVF. Worldwide, only a few thousand babies born from frozen eggs. We obviously have less frozen egg data, but the early data that we have is very reassuring, making egg freezing a very, very viable process, and nobody should be making embryos if it doesn't fit their life circumstance appropriately. There's no medical justification for that right now, even if there might be a subtle difference. From my perspective, what our lab tells me is that our numbers are basically the same in terms of survival rate and implantation rate. We are seeing that embryos made from one thing that we do, and I'm curious to see what Dr. James does when we use a lot of frozen donor eggs, because frozen egg banks here in the United States are big, and it's a great way to avoid a long waiting list with a donor and get a donor that you like, is to use a frozen egg bank. And what we're finding is we are discouraging our patients that are using donor eggs from doing genetic testing, because what we're seeing is that even though the implantation rate is the same as with fresh eggs, we're seeing slower blast progression. So first of all, frozen eggs have to be fertilized using ICSI. You cannot just use routine IVF. You have to actually inject the sperm into the egg, because once you freeze and thaw, there's a change in the zona, the shell around the egg, that requires that the sperm be injected into the egg in order to fertilize. And then once you have fertilization, which appears to be the same as with fresh eggs, the percentage, and the rate that they get to blastocyst seems to be a little bit slower than the blast progression rate from fresh eggs, at least in our lab. And so they're not ideal candidates for genetic testing. And I know our genetic testing philosophies are different, because we tend to be super aggressive about genetic testing. We have a huge program, and a lot of our patients want genetic testing. And then when they are in the donor egg program, we actively discourage them from doing that with the frozen eggs, because we feel like they're just harming those embryos that they made from frozen eggs. So, Dr. James, I'm wondering, are you seeing that at all? Like, what are you seeing with the blast?
Yeah, I think we are seeing slightly less blastocyst development. I think it's difficult to compare from a genetics point of view, because I think that the feeling is slightly different. We do less PGTA and genetic testing over here. We use frozen donor eggs as proof of concept, as many clinics did, and that we first started offering the use of frozen eggs to women who needed egg donation, using frozen eggs that we had banked from our egg sharers, offering those sort of without charge until we had enough confidence in our processes. So I think
I think it'd be safe to say also that the reason that we don't have as much data from the frozen eggs is because women haven't gone back to use them. It's still a newer technology where IVF is over 40 years old. So 8 million babies after 40 years, let's see once egg freezing is more of a routine, how the statistics on that. But I think it's safe to say that, especially when you freeze a younger egg, that it will always be kind of better than the older egg.
Tracy, can we go to the last slide where our emails are? Because we're almost out of time. We are out of time. But Valerie, I'm wondering if you could leave us with something. I'm wondering if you could give the people listening who are considering egg freezing maybe your top 5 questions you should ask yourself before, or something, not to put you on the spot, but
yeah,
a short list of those questions. Welcome to our Wednesdays at noon.
Yeah, no, I think the top key thing to think about is, are you okay with being a parent that is not your DNA? Once you've kind of rectified that question, I think you'll have a more clear vision if egg freezing is right for you. If your answer to that question is, no, I'm not okay with becoming a parent without using my own DNA, then egg freezing could be a really great choice. I think that if you also consider the trajectory of what all your goals are, is there advanced schooling you want to get done? Do you have a really demanding career? Are your relationships, are you confident that those will move into marriage, family, and kids, or any of those components that would alleviate the need for fertility treatments? And then also too, I think just being mindful of your health, that, you are the youngest you'll ever be right now. And if you were to delay parenthood into your 40s, are you okay with the concept that you might not be able to, get pregnant as easily? And so once you kind of factor in those concepts, I think deciding if egg freezing is right for you will be more clear. I think also always starting with your fertility checkup, your fertility timeline, getting your AMH and intrafollicle count is always a good thing to do. I wish they had done that during my OBGYN general appointments in my 20s. So I had kind of a progression of how I was doing over the years. And that way it could kind of relieve any burden and or helped me decide if I would have taken advantage of egg freezing sooner. But, you know, we're in the time period where this technology exists now, and it's a great option, and it's the best it's ever been, and it's a very viable option for women to be proactive about their fertility and timeline, so we can compete on the same level as men, essentially.
Thank you. Valerie, can you put your handle, like your where how people can find you online in
Sure.
the chat again?
Yeah, sure.
And then I guess like to everybody on here, the last question is, if I'm interested in egg freezing, what is my first step? What do I read? Who do I contact? Besides Valerie and IVF Babble,
I think I would say, you know, if you're in the UK, you know, do a little bit of research in terms of the clinics that offer it. Go to some of the egg freezing open evenings. You know, get a feel for the clinicians. I think there's going to be, you know, a number of clinics that do it well and do it equally well. I think it's going somewhere where you feel comfortable with the clinic and comfortable with the people, and that's going to be key.
Very good point. Dr. Chen, anything to add?
So I agree. I think IVF Babble is a great resource. Valerie is out there and can help provide information. Resolve.org is another good resource, and ASRM. You want to, you know, go someplace. Most people are living, you know, kind of near an maybe more than one IVF clinic, which is nice, and ultimate. And a lot of people are actually doing egg freezing now. So I think the big thing is to find a place with a good reputation, and then, like Dr. James said, you want to feel comfortable.
And Valerie, do you still have your podcast?
Yep, Eggology Club is the podcast.
It's a great podcast. It's a great podcast. And I think also like a good place to start, like if you just want to listen to it and hear Valerie, what she says, or interviewing people and have it still feel private, maybe not go out there. It's a great place to start in terms of Valerie's own experience and the people that she gets to talk to on there. So that's an awesome one as well. And your blog. You have your blog too, right?
Yeah. Experience.
So Valerie's put out a lot of good info. So you can learn a lot from there.
Great. Well, thank you, everyone. As always, this was great. Thank you, Valerie, for joining us, and everybody that's here. We loved it. This will be recorded, and Sarah and Tracy will send out a link to the recording in usually a couple business days.
Great. It was awesome
Brilliant.
talking
Thanks,
to you
guys.
all.
Nice to see you all. Bye.
So nice to see everybody. Thank you so much.
Stay safe.
Take care.
Bye.